Well, as you can tell, I'm not John Thorpe. I'm a lot shorter, and his hair is a lot shorter than mine. But I'm going to give his lecture that he had prepared, and then I'm going to give a little bit of my own personal perspective. So I will read for him. Thanks for the opportunity to speak to such a distinguished audience and mingle with like-minded men and women from what I will call throughout my remarks the culture of life. Since that hot August Sunday in 1982, when the then 5-year-old Carrie Beth hugged me tightly, kissing my neck, and the warmth of her saliva on my neck convinced me of her humanity and her dignity, I have been a fellow pilgrim with you and the Lejeune Society in this struggle against the inhumanity of prenatal diagnosis and the purposeful obliteration of fetuses with Down syndrome and other developmental disorders. As the subplot of my presentation, I have included a photo of one of my friends with Down syndrome. Robert Walker's exuberance at a professional wrestling match expresses far better than my words can the vitality and joys that shine through humanity and will not be overshadowed by limitations or labels. I will not reiterate what earlier speakers have taught us about the new technologies that can isolate and sequence fetal DNA from the maternal bloodstream. But I will share my prediction with you that this will culminate in an almost universal uptake of prenatal diagnosis. We're on the threshold of a world in which every embryo with Down syndrome and other chromosomal abnormalities will be identified before most mothers, friends, and families can detect her pregnancy. There are numerous reasons for my prediction, which I will attempt to delineate for you. First, the technology is non-invasive. Now, common sense and the fear of a 20-gauge needle inserted into a woman's abdomen and the 1% loss rate of otherwise normal babies had a chilling effect on prenatal diagnosis years ago. This was often true even if a couple had not thought through what they would choose to do with the results. Okay. Very good. No problem. Next, these tests, this non-invasive testing, will be professionally marketed. Remember, doctors are horrible at marketing. They're horrible at marketing themselves and horrible about marketing their skills. And there's an underlying premise that clinicians who need to advertise are those who lack satisfied patients to do the word-of-mouth advertising we all rely on. So in the past, prenatal diagnosis was something that was done by the physician, and very few of them would advertise the procedure. But the companies selling these tests will spend money on getting their messaging, and they will get it right. All one needs to do is glimpse the first wave of advertisements to recognize the truth of that prediction. As mentioned earlier, testing will be offered early in pregnancy in the primary doctor's office. These tests will be described in a sentence or two at most. Would you like prenatal testing to find out if there's anything wrong with your baby? Or, here's a stack of papers, sign at the bottom, with no mention of the downstream consequences. Every obstetrician or midwife in the room who lived through the move of serum screening from academic health centers to the countryside knows how minimal that the counseling is right now. Finally, it will be marketed to a generation of parents who are super saturated with information. We're used to glancing at our phones and knowing how bad Duke is getting beat, the price of our favorite stock, and the temperature in Chapel Hill. Information itself is seen as an absolute good, with no attention paid to any harms. Younger people will even be asking themselves, how can information ever harm anyone? I would relate the tale of my son's travel to the Virginia mountains, guided by his GPS, where he ended up asleep on a couch in a home that did not belong to his grandmother, and the consequences of that information. When given a choice, most young Americans opt for more information, and I predict the same will be true for the free fetal DNA tests. If and when the widespread uptake I am predicting occurs, the change will overwhelm our tired and antiquated system of counseling. Current clinical counseling, when done by doctors or nurses or genetic counselors, is rarely informed by actual physical experience with men, women, children, and families living with chronic lifelong developmental disabilities. This counseling focuses on risks, recurrence, mechanism of action, and the end result is that the families hear the worst case scenarios that are infused with pessimism. Often the counseling is done by young men and women who don't have any children of their own, who have indeed delayed childbearing to obtain the academic credentials they needed to become the clinicians who counsel. They have idealized and hypothetical views of children that have not been tempered by real-life experience. Those of us who have raised families know that all human beings are flawed, and they're all imperfect, even our own children. And there are conditions far more heartbreaking than Down syndrome. The cruel irony of the testing and the end result is that none of the ads or commercials will disclose the fact that the sole purpose of this knowledge is to offer, if not recommend, the treatment of death for the individuals in utero in whom the developmental disability is detected. Most couples will be reassured, and a few will be startled by the news that they have conceived a disabled child. Shortly after this disclosure, they will be given the horrible choice of a known outcome. If that is chosen, that known outcome, then death will be operationalized by the care team. Even couples who would never terminate a crisis or unintended pregnancy are placed in this nightmarish scenario. Without a carefully planned, well-funded, and widely available response from the culture of life, more and more families will innocently start down the assembly line, culminating in the death of individuals with developmental disability. The Roberts and the Carrie Beths of our world could disappear, and we will have even less exposure to their beauty and their voices. Their absence will perpetuate the falsehoods and pessimism that's currently inherent in the counseling that we receive today. And they will be eradicated not from the society down, but from the individual up. Remember what Solomon admonished: even the tender mercies of the wicked are cruel. But, like any crisis that we face, the revolution in non-invasive prenatal diagnosis presents us with a real opportunity. Prenatal care clinicians will lose the financial motivation to perform prenatal diagnosis, as the $1,000 for an amnio or chorionic villus sampling will flow into the pocket of the company supplying the test. I predict this loss of reserve and involvement will greatly erode the motivation to close the loop and terminate the pregnancy. Here is our opportunity. It's an opportunity to soak up this newly found capacity and expertise heretofore spent on prenatal testing procedures and shift it into comprehensive counseling and treatment programs for these families and their offspring. We must widen the availability and capacity of perinatal centers that have the capacity to manage pregnancy, delivery, and newborn care for these affected families. These will require not only experts in imaging, obstetrics, neonatology, and pediatric surgery, but also mental health professionals and counselors. Families will need individual, couple, and spiritual counseling to support them. One can imagine peer-led support groups that give them a forum for practical advice and an outlet to express their fears and frustrations. Some of these babies will have conditions for which we lack adequate treatments now, as Dr. Kaufman said, but maybe not in the future. And they will die early in their lives. We must have hospice-like palliative care available for these children. Their families will need even more physical, psychological, emotional, and spiritual support. Rather than having to live with the knowledge that they ended their child's life, these parents could grieve their loss without the additional burden of having made that decision. Many of you are rightly grumbling that current practice desperately needs such a comprehensive approach. And I don't disagree, but can only point out that we are hearing the first rumblings of a tsunami that will crash on shore with a wave of families in need of comprehensive care, and the culture of life must begin to prepare and prepare now. Others have muttered to themselves that I'm disconnected from financial reality. While this will be expensive, it is low tech, and much of this can be done by volunteers with adequate professional coordination. The corporations offering the tests are poised to reap huge profits, and why shouldn't these profits be taxed or donated to support a network of comprehensive care centers? We have to ask. In closing, the state of Sparta and Spartan culture, with its official policy of infanticide for abnormal newborns, is often mentioned by culture of life commentators. Affected babies were taken into the wilderness, and they were left there, abandoned to the elements and the animals. We rightfully compare Spartan babies to fetuses with developmental disorders in our own culture. But I would carry this analogy even further and opine that we are worse than Spartans. In that ancient city that was pre-Christian and warlike, there was no concept of individuality and no treatment for birth defects. Society decided to practice infanticide and did not dump the horrific choice into the autonomy lap of the baby's mother. But our society and our prenatal practice abandons not only the baby, but abandons the mothers and fathers of these children. They start with the highest intentions and hopes, only to get limited information when abnormalities are uncovered. When the culture of life should surround and embrace them, they're abandoned, and they're left as prey to darkness and inhumanity. We must take immediate action to come to their rescue. I just want to thank Dr. Thorpe for providing this part of the lecture. And now I'm going to talk with you a little bit, kind of wrapping up from more of a right brain approach than maybe a left brain approach. I think part of the problem that we see is our attitude. What attitude do we have? What approach do we have when we as a caregiver have to convey information and bad news to this family? Our culture says, well, we don't really tolerate visible imperfection. As we've all said, every one of us has abnormalities. Some of them are visible, some of them aren't. How many of us here have a perfect genetic code? We don't know. But we're assuming that a perfect genetic code equates with happiness and a good life. How do we know that? That's a huge cultural assumption. The culture of death values a human being based on their contribution to society. But who runs that society, and how do we decide what is good and what is healthy and what we're working toward? For the culture of death, the greatest good is absence of pain. But is that the culture, is that really what provides the greatest good? We make quality of life judgments, and we value radical autonomy. But the culture of life comes from a completely different set of basic assumptions. One of them is the recognition that all human beings are flawed in some way, but that flaw does not take away their intrinsic value, the value of the fact that they exist, and the fact that they bear the image of God. The culture of life also considers the greatest good the ability to sacrificially love another human being. That involves pain, and that involves embracing pain. The culture of life says that every human life is of infinite value, whether it lasted a minute or 95 years. And the culture of life values family rather than radical autonomy. Not only the cultural assumptions that we make, but the medical assumptions that we make also interfere and get involved in how we communicate these kind of diagnoses to patients. As physicians, we are taught to focus on diagnosis and treatment. Treatment of the very limited things that we can treat. We often have little personal experience with disabilities. We often have little personal experience with children, as Dr. Thorpe mentioned. Many of us delayed childbearing for a long period of time. Many physicians are busy enough that they have, even if they have children, they have very little personal experience with their children. We're also threatened with the threat of wrongful life suits. And as I talked about before, not only the threat of wrongful life suits, but the limited amount of time that we have with patients. And also many physicians have very little emotional margin. And this may not only be physicians, but midwives or nurses or anybody who's in a high-pressure situation. Again, that's sort of the crank through the patient's mentality. And here we have to encounter what is really a heart issue with the parents. The parents want to love their child. They want to protect their child. They want to see that their child is beautiful. They want compassion. They need to grieve. And they want the security of knowing what's going to happen next because their whole world has just exploded. So what do we do with recognizing our own limitations, recognizing the needs of our patients? How do we convey this diagnosis of bad news and yet bring hope in the pain that we know that we're going to have to give this family? I've, in researching for this very briefly, I came across some very good do's and don'ts, which I modified a little bit based on my own personal experience. And I'm going to take a minute to tell you about that. My husband and I went through a child with a congenital anomaly, a hypoplastic left heart, one of those things that Dr. Smith said was a terrible thing, and it was indeed a terrible thing. I understand a little bit from the side of a parent listening to a physician trying to convey information. And not only that, but having another physician, my husband, who's also a physician, listen to the same doctor and hear an entirely different thing. So what you say as a counselor is not necessarily what's heard as a patient. Okay, there's what you think, there's what you say, there's what they hear, and then there's what they think that means. Okay, there's all of those places where communication can break down. And in this case, when you're trying to convey hope in pain, communication and accurate communication is essential. So accurate communication does not mean an information dump. Here's the 5 studies that pertain to it. Here's the protocol at University of Michigan, and thank you very much. I'll see you tomorrow. That's not communicating information, and that's not really relating to what the patients, families need to hear. So I'm going to go through some of these, and then I'll interject my own comments as well. The first on the list that I saw published was, don't say that this diagnosis is incompatible with life. That's a ridiculous thing to say. The child's already alive. Therefore, it's not incompatible with life. If a diagnosis were incompatible with life, the child would be dead. Okay. So the child in the mom's womb is alive. And you need to recognize and help the parents celebrate the life of the child that already exists in her womb, for whatever time the child is given to live. Don't refer to the child as the trisomy 13 in room 6. Okay? Call the child, even the unborn child, if the unborn child has been named, by name, because we call human beings by their name, and this child is a human being. And this is a way of recognizing for the parents that your child, though they may be sick, is a human being that we all care about. Don't make dire predictions, especially predictions made without a lot of research and out of ignorance. This child will not survive more than 6 hours. This child will not survive to take a breath. You don't know. And the reason you don't know is that what we know as medical practitioners is based on averages. It's based on statistics. We take the mean and we say, this is what it means. But there's a bell curve. It's a biological process. We don't know what's going to happen to that particular child. Also, don't say things like the child will have a life of suffering. The child will ruin your marriage and family. These are things that you don't know, and no human being knows. You don't know what's going to happen and the function of that child in that family. Do show respect for the meaning that loving the disabled child gives to the family. Recognize that many disabled children have very joyful families who love and care for them. And recognize that predictions are based on statistics that may not apply to that particular child. Don't say, well, you can always have another child, because the implication is this child is worthless. Do respect the love and the meaning that the parents find in caring for this child, even if for a brief time. Don't say, there's nothing I can do for you, because that is actually a lazy excuse for not investigating the support services which exist for the parents and making those support services available. And as practitioners, it is our job and part of our responsible care for our patients, before we go into that room, to know not only what the diagnosis is, but what are the options that parents have. So when you go in to a room and you know you've got bad news, prior to going in, let's say it's Down syndrome, since we've been talking about it. Before you even enter that room, you've done 6 hours of work pulling up the local Down syndrome support groups, getting the names of 6 people who are willing to talk to this patient, and you go in and you say, you've got a beautiful child, and lovely little girl, and you hold the baby, and you say, wow, I have to tell you some things that we found out about your little girl, about Sarah. You know, Sarah has an extra chromosome. And what this means for her is that she has some problems, or she may have some problems in the way her brain develops. But there's a lot of good things happening right now about this particular diagnosis. And this is some of the things that are happening. We call this diagnosis Down syndrome. Here's where you find out about it. This is how it's spelled. Here's a couple of good resources for you. And we also have a number of other parents who have children just like your Sarah. And here are the names of them, and they wanted me to be able to make available to you their phone numbers. So if you have questions about what it means to parent Sarah, they're there to help you. That preparation happens before you walk in the room. And that way, when you have blown the floor and the walls away from this patient, you provide them something to stand on. They can see that, yes, this is a serious diagnosis. Yes, it's a problem. It's going to change my life. But there are people that have also had this diagnosis, and they've walked through this, and I have someone to talk to. What unfortunately oftentimes happens on rounds, and you've all seen it. Mrs. Smith, well, we've got some bad news for you. Your baby's a Down syndrome baby. These are the things that we can do. You know, you'll be here in the hospital a couple of days, and here's a pediatrician who works. And we're sorry. I mean, what does that do to empower the parents to deal with the diagnosis? So when we go in, what's on our brain is, let's empower this family to raise this child. What does a family need to have to be empowered? They need to know that it's not hopeless. They need to know that other people have gone through it. They need to know that there's some answers and some options for them. But don't give families false hopes. Don't say, well, you know, the cure for Down syndrome is right around the corner. We've got this, you know, this article that came out yesterday that says the cure's on the way. Okay, it's not true. You have to be very realistic, because false information does not empower patients. It's accurate information that empowers them, and being able to be in network with other people who are walking through the same journey. Do give families accurate information about medical treatments available, as well as the limitations of that treatment and the information. And encourage families to recognize that there is a miracle that can happen in their life when their transforming love allows them to care for a child even through their suffering. Don't shut down the parents' need to grieve and to understand and to regain control. Because what's happening from the parental side is, you have just shattered all of my hopes and plans. You have changed everything in my life. And you're going to walk out without any kind of support. Do listen to them. Connect them to other parents, and enable them by giving them information, and give them decision-making opportunities. Above all, recognize that all children, regardless of impairment, illness, or disability, are human beings who can be loved, cared for, and leave a positive mark on their families. For this and so many other reasons, they deserve our respect. Now, I want to share with you a couple of support services which you can find on your own, but I found these particularly helpful. One of them is an organization called perinatalhospice.org, which is kind of a central clearinghouse for all kinds of information about perinatal hospice. Well, I'll talk loud until I get the mic back. I think the key concept that's being related is, this is a human experience, and as practitioners, We get involved and we intersect with that human experience for an hour, maybe a day. But the parents have that human experience for the rest of their life. And so what I want to give you a vision of is that we can do things to make that memories less painful, and as the video said, to allow the parents to take the first steps toward healing.